Hello and welcome to Brewing Brilliance, a podcast where we talk to academics from across the university who are involved with the Healthy Ageing and Chronic Conditions Research Institute. We will be speaking to researchers who are leading innovative interdisciplinary approaches to promote lifelong health, delivering improved interventions to manage chronic conditions more efficiently. These sessions are essentially opportunities for us within the Healthy Ageing and Chronic Conditions Research Institute to meet colleagues from across and beyond our faculty to foster knowledge sharing, collaboration and networking. My name is Adrienne Cleverly and today we are joined by Dr. Emma Rees. Emma is an Associate Professor of Healthcare Science, and what's very interesting about Emma is that she is in a clinical academic role. Emma is registered clinical scientist specialising in heart scans, and she has an honorary contract with the local health board. Her work includes direct patient activity, clinical research, leadership and education. Hello, and thank you for joining us today.
Hiya. All right, thanks for inviting me to come. Pleasure to chat with you.
So you've got lots of different elements to your role. So do you think that with these different elements, they've kind of helped shape how you deliver some of your research?
Yeah, definitely. I think having a really strong clinical background means that I've got a foot on the ground in thinking about what are the most pressing challenges facing patients and healthcare professions and organisations. So that helps me decide what to prioritise in terms of designing research. It also helps me to engage with patients, members of the public and other clinicians in deciding how that research is best designed. What's the point of it? You know, what impact will it have? Who will benefit from it? So the clinical side is really important there. But then also from the academic side, having the robust sort of scientific methodological knowledge and all of the support around me from more senior professors and sort of the research hub and people like that, that really helps to make sure that I'm doing things in as high a quality way as possible. And that's not how I approached research when I worked in the NHS. So, you know, to have that sort of the more academic side has been really, really valuable in improving the research that I do. I think also having the time. So in a clinical academic role, yes, I've got time to do heart scans and be with patients and make a difference to care. But then I've also got time to think, to read, to plan ideas, to work up research projects. And I never had that when I was in the NHS. So I feel like I've got the best of both worlds.
You've got a nice balance of two different things going on.
Absolutely. And what's amazing about it really is when I was training in the NHS, I never imagined that this sort of career would be possible. I thought I would either stay in the NHS or become an academic, and I wouldn't be able to do the both. So, and I didn't want to give up either of them. So the opportunity to do the both is so satisfying and rewarding. And I think from the point of view of my teaching, it means that the passion I still have for the job and the high levels of satisfaction I have in both the clinical and the academic work, that feeds into the teaching that I do. So hopefully the students get a real sense of, you know, what a clinical academic career is like. And I'm hoping that it inspires a few of them at least to think about more research. Because all too often when we're teaching people on NHS professional courses, yes, obviously the focus is to go into the NHS and to really make a difference with their clinical work. But we do find we get, you know, some students are really interested in clinical research. And I think it is helpful to try and inspire them right in their undergraduate degree and beyond. Okay, well, what might that pathway look like?
Yeah.
You know, and there's that saying, isn't it? You can't be what you can't see. So if they see people who have done it or who are doing it, then it makes it easier to think that it's possible.
And they're two contrasting, but they work together quite nicely, don't they? And they've sort of helped you with, well, can you tell us a bit more about the research you're doing with the heart scans at the moment?
Yeah. So my passion has always been that everyone should have access to high quality heart scans, no matter who they are or where they are. And I have become aware through my clinical work that not everybody has access to these heart scans. So at the moment, they're done by experts like me in a hospital. But you can imagine that if you're someone who can't get to a hospital, Let's say you're an elderly person and you need to have care in your own home, or you're in a care home. Going to hospital for repeated tests and consultations can be really difficult logistically, and it can be quite upsetting if you have something like dementia. So I became aware that there was an issue where people who perhaps are more likely to have heart disease because they're older, and lots of heart disease is more common as you get older, they're the ones who are least well served by our current organisation of services and where tests are. So my research is about taking the scan, or a version of the scan, closer to the patient. So I've got Health and Care Research Wales Advanced Fellowship grant. And really what we've done across several phases of work is we've taught advanced nurse specialists who already see those older patients in homes and in care homes. They're already doing assessment of the patient, deciding how to manage some of their condition, and they're supported by a medic. We've taught them to add a limited heart scan to what they do now. So imagine, like now, when you have somebody assessing your heart, they use a stethoscope, right?
Yeah.
But a stethoscope listens to sounds of the heart. It doesn't actually tell you exactly what's happening. It only gives you clues. A heart scan gives you much more visual, accurate information of what the heart's actually doing. So these nurses had said to us, look, a lot of patients refer to us in this hospital at home service, they call it. It's like a virtual ward, and they go out to patients to see them. A lot of them are breathless. And we've got to try and work out, is it the heart that's causing this? Is it lungs, or is it something else like anemia or cancer? And what they were telling us is that the tests they've got now just aren't specific enough to help them differentiate between those things. And that's really important, because if you've got to decide whether to admit somebody or to refer them to a specialist, you really want to know, am I sending them to a heart specialist and coronary care, or a lung specialist, or do I need to think about palliative care? Or, there's so many different factors. And so what we have thought is that by adding the ultrasound scan as a sort of extension of what they do with the stethoscope, they might be able to better decide what to do with those patients. So we've tested adding the test as we call it a triage step. So it's not instead of a hospital scan. It's not got all the machines we're using. They haven't got all the bells and whistles of a big piece of hospital equipment. But it allows the nurse to answer a clinical question. And that question is this person's breathlessness likely to be because of their heart? Or is it more likely to be something else? So it's improving their confidence in deciding what's the next step for that patient in the home.
And almost the least disruptive step as well. Because like you said, if you've got someone living with dementia or something like that, taking them somewhere unnecessarily can be really detrimental to them, can't it, in terms of their care?
Yeah.
Is it that experiences of those, like working with the nurses and working with the patients, that got you thinking about doing this and making it wider? Because it sounds like you've encouraged people to be involved quite early on in this research, because it sounds like there's lots of different inputs that sort of have helped shape this. Would that be a fair assumption?
Absolutely. I think all of the elements of innovation and research work that I do, the design and the idea are all driven from patients or clinicians doing the job and identifying what the challenges are now. And to me, it doesn't make sense to try and come up with a solution and design and test it without them.
Yeah.
They need to be involved in it, because if we were to show that nurses could do this accurately and that it made a difference to patient care, we'd want to roll it out, wouldn't we, across health services in Wales and UK and beyond. It's not going to roll out very well if we haven't designed how they do it and when they do it in such a way that they think it's feasible, that they think it's a good idea. So one of the things we've tested in the research, we've tested things like, can they do it safely and accurately? Do they make sound decisions? But we've also tested things like, how long does it take them to do it? What's the patient view of having a scan in their own home? What's the organisation view of it? What support structures are needed around it? So right from the beginning, we've started thinking about all of the factors that would influence implementation. Okay, so
Yeah.
we're on a clinical trial now where we're just about to work out, really on a larger scale, is it effective in the way that we've proposed? So we've done the preliminary tests, we've designed the training, as I say, we've done all this accuracy testing and reliability testing, we've done a pilot test, and we're now expanding that out. But I think all the way through, it's been really important to have a mixed methods approach, where we're getting quantitative data on what happens.
Yeah.
Things like, what is the diagnostic accuracy? What's the feasibility for the protocol being used? What are the outcomes for patients? But it's been equally important to me to get qualitative information from the nurses around their experience of doing it, of fitting it in with the rest of the clinical pathway, their views on changing a pathway, their attitude to change,
Yeah.
how they feel their team dynamic or their support within the hospital has an impact on whether they do this and how well they do it.
And
so
that will
that's
influence,
really important, I think.
Because it will sort of influence as well how you move forward with it, won't
Yes.
it? Because am I right in saying that this hasn't been published yet, has it, this work? Or
So we've had elements of the work, probably 4 or 5 elements of the work now have gone to international conferences. So we've talked about the work at conferences, and we've got papers in draft form, but almost we're keen not to publish it too soon, because I think from a clinical perspective, people are interested in the whole thing. So we could, for example, salami slice the research up and publish a training paper and then a feasibility paper and then the clinical trial paper. But I think a lot of people are interested in more, what is the whole bigger picture of how this fits together? So we're thinking about at the moment, can we fit that into one decent sized paper, or have we got to split it up a bit? But what's been really interesting to me, I think, is that just by going to conferences and chatting to people about it, there's a huge amount of interest in this work. It's quite controversial work.
okay.
So there are experts within cardiology and from within my profession who are not convinced at all that this is the right thing to do. They feel that heart scans should only be done by people like me in an expert environment with an expert piece of machinery. And there's been quite a lot of resistance to research around these handheld ultrasound scans being used in community environments. But what's helped me is the fact that I come from the same environment as those experts. I understand what their concerns are and what the risks are. And I've got a really firm handle, I think, on assessing for unintended consequences, misdiagnosis in the research. And so because I'm talking to them about, look, that's my concern as well. And that's why it's important we get involved in research like this so that we can really make sure that this is the best solution, because it might not be. There might be a better way of answering the same clinical question. That's helped to overcome psychological barriers that people might have.
I was thinking as well, as you were saying that, it's like you've kind of gone full circle, because this is what we started with, in the sense that this was one of the interesting things about your role, but it's equally beneficial massively to what you're delivering, because you've got both hats on. You understand what the outcomes look like for both people. Do you think that's added to the success of this research so far?
Yeah. And also I think it improves my credibility in terms of being someone who's a sort of proponent of this. I'm saying, look, I think this could work if done properly. The fact that I'm coming to it with an expert heart scan person hat on, with those clinical links, I think adds a little bit of credibility, to the argument, if you like. So yeah, I think that's valuable. And how that's been demonstrated to me as well recently is, bear in mind, this work hasn't been published yet, beyond conferences. I had an invite from British Society of Echocardiography recently to go and present my research design and preliminary results to their council. So it was a closed meeting of their council. And the reason they asked me to do that was because they could see lots of papers being published around handheld ultrasounds out of hospitals by non-experts. And they had real concerns about the way the research might be done and what it might be missing. And they'd heard through conferences that I was doing things a bit differently, and they wanted to understand why and how I was doing it. So I got to go and present to the National Council, and they're the people who write guidelines for the whole of the UK around heart scans and who should do them and when and all the rest of it. And that was such a brilliant experience, because it meant not only could I sort of say why my approach is different and how that might be of benefit to patients and organisations, but it meant I got to ask them, what are you worried about? What are you concerned about? Tell me what your thoughts are on this, because I'm really open-minded to those criticisms, and I want that to inform my research moving forward. I feel like the best research comes from understanding the perspectives of people who don't agree with you.
Yeah, because it forces you to look at it from a different direction, doesn't it?
Yeah.
On that, do you think that having that attitude of getting the people that don't agree with you, do you think that's something that really pushes the research forward more?
Yeah. And I hope anyway, I mean, I don't know yet because it's still a little bit early on, but I hope it means that if we demonstrate our results are effective enough that this should be implemented, that we've already started to overcome some of those barriers to implementation. So I hope that, if we're looking to change practice on a national level, the fact that we've already got the views of senior stakeholders and decision makers and people who draft policy in this area, the fact that we're already thinking about what their perspectives are and what their concerns are, hopefully will be of help.
Do you know, this sounds like an incredible piece of work. What I think I might have to do, because this conversation is so interesting, do you think when you get further down the line, you'd be happy to come back and tell us the outcomes of this research? Because that would be, I'm sure people listening would love to know what the outcomes are of this as well. Because it is life-changing, like you say, for more than people that are just sitting here around us. Could potentially be worldwide, couldn't it?
Yeah, and I think one of the things that's really helped me to understand the scale of the impact this could have is some of the resistance that we were hearing was, well, there aren't many people who don't have heart scans in hospitals. If people are breathless and they've got suspected heart failure, everyone can access a heart scan in hospital. And I felt anecdotally from what I was hearing from nurses that wasn't the case. So part of what I've done is to work with the SAIL data bank to look at everyone who's got a heart failure diagnosis within certain dates in Wales, so across the whole of the country. And I've mapped what tests did they have and when did they have them. All from using the routinely collected data, that's in the electronic health record. And what it shows is that probably only around 30% of people with a diagnosis of heart failure have all the right tests according to NICE guidelines. We don't really know why at the moment. We don't know if it's a problem with how they're recorded in the electronic health record or a problem with access to tests. But what we know is the GPs see what's in the electronic health record. So if they're not seeing a heart scan result, they can't act on it. So even if the heart scan is being done, if the result's not in the records, they can't act on it. So I've been able to demonstrate for a cohort of 51,000 people what tests they're having and when they're having them, in order to sort of go back to the cardiology experts and say, what you think is happening might be happening in your patch for your clinic, your specialist service that you run, might not be happening everywhere else.
And it's kind of, you can give it that blanket, can't you? So that everybody's getting a good treatment, I guess, or ineffective.
The treatment there that you raise, that's really important, because the heart scan tells us about if heart pumping function is a problem, but also how bad it is. And that has an influence on what medicine the patient's prescribed. So in that SAIL data bank work, what I also looked at is what proportions of people are on the right heart failure medicines, and it's shockingly low for Wales.
Wow.
So we feel that not having the right information from the test might have an impact on whether patients are on the right medication. Of course, that needs to be dug into a lot more deeply in the research. But I think, it's that so what picture. So people might think, well, if they don't all have a heart scan, so what, as long as they get the diagnosis, et cetera, et cetera. But actually, we think it's having an impact on their care. And we know that certainly for heart failure, if people aren't on the right tablets, they don't live as long and their quality of life is worse.
And they care.
Yeah. So, it's been interesting because if people hadn't said to me, we don't think this is a problem, I perhaps wouldn't have gone out to do the sale work.
Yeah.
Because I've said, okay, well, you think it's not a problem. Let's look for evidence to see if you're right.
Yeah.
Because if you are right, maybe we need to be focusing on something else or having a different approach. But actually, it appears that they're not. And now I can go back to them with objective evidence that says, look, what do you think of this? This is the picture we're getting from real world practice from the electronic health record. So there's been a lot of interest in that data, partly because of the size of it and because it reflects practice in Wales. And those data sets are what I was invited to European Society of Cardiology Congress to present. So that was interesting because obviously that's not just people from the UK, that's people, from all over Europe, excuse me, and sometimes wider. And they were interested in, okay, maybe in our country we should look at what our rates are.
Because it's not just people in Wales or the UK that have heart problems, is it?
No.
It's... Yeah. Well, I'm loving this. This is so interesting. But unfortunately, we're going to have to move on. But you must come back and tell us some more about this because it's just, I'm sure I'm not the only person that's going to find it interesting. So if you would like to find out more about this topic, then you can visit, are you happy for people to visit your staff profile and reach out to you?
Yeah, absolutely.
I should have checked that first, sorry. No, but you can visit Emma Rees's staff profile page on the Swansea University website. That's all from us today. If you have enjoyed and would like to find out more about this podcast and Swansea University's research, then please follow us at Swansea University. We are the Health and Life Science Research Institute, the Healthy Aging and Chronic Conditions. Thank you. And thank you so much for joining us. I loved that. Thank you.
Thanks for having me.
Thank you.